Welcome. Today we are exploring how stem cells are transforming medicine, focusing on innovation and ethics through Parkinson's disease. Stem cells are the fundamental units of the body, unique because they can self-renew and differentiate into many cell types. This is crucial for disease where specific cells die and cannot naturally regenerate, such as the neurons lost and Parkinson's disease. There are several sources of stem cells, each with different implications. Embryonic stem cells are pluripotent and highly versatile, but they require the destruction of embryos, which raises ethical concerns and limits their global use. Adult stem cells avoid this controversy and are widely used in bone marrow transplants, so their potential is more limited. A major breakthrough came in 2006 with induced pluripotent stem cells, or iPSC case. Scientists reprogrammed a patient's stem cell back into embryonic-like state, become the exact neuron type destroyed by Parkinson's. This innovation opened the door to personalized regenerate medicine during treatment from symptoms management toward actual tissue restoration.
Stem cell science has evolved far beyond simple cell replacement, and the first major innovation is the combination of iPSCs with gene editing tools like CRISPR, and this allows correction of mutations and creation of patient-specific neurons and even mini brains for drug testing. Second one is mesenchymal stem cell-derived exosomes contribute to reducing inflammation, which is crucial in disease like Parkinson's, where inflammation accelerates degeneration, and these exosomes work as a supportive therapy that enhance survival of transplanted neurons. And third one is 3D bioprinting reduces structural scaffolds that help transplanted cells survive, integrate, and form proper neural networks. And in Parkinson's, precise structural support is especially important because dopaminergic neurons must connect to motor pathways accurately, and together these innovations mark a transition from slowing disease progression to restoring lost function. Parkinson's is ideal for stem cell therapy because it involves the loss of a single neuron type, dopaminergic neurons, and current treatments like levodopa, deep brain stimulation improve symptoms but cannot stop neuron loss completely, and this makes Parkinson's disease a prime target for regenerative medicine.
Symptoms include tremor, rigidity, and bradykinesia, caused by dopamine deficiency in motor circuits. Non-motor tissues like depression and sleep problems show dopamine's wider role. Diagnosis relies on bradykinesia and imaging, but often occurs after significant neuron loss, highlighting the needs for stem cell therapies to replace lost neurons, rather than repair what cannot regenerate naturally.
Now talking further, iPSC-based therapy for Parkinson's directly addresses the root cause, the loss of dopamine-producing neurons. The process starts with reprogramming a patient's skin cell using Yamanaka factors, turning it into a pluripotent cell without using embryo. This provides both biological compatibility and ethical safety. Next, growth factors like SHH and FGF8 guide these cells into becoming midbrain dopaminergic neurons. Their identity is confirmed using markers such as tyrosine hydroxylase that indicates they can synthesize dopamine. During the transplantation, surgeons implant the cells into the putamen, the region that normally receives the dopamine signals. Over months, these cells extend axons for synapses and integrate into the motor circuit. It's also important to mention clinical trials that provide measurable evidence. PET scans show increased dopamine production, and patients demonstrate up 20 to 30% of improvement in motor scores. New neurons survive 18 to 24% with no tumor formation reported in the controlled trials. Personalized iPSC treatments have reduced off time by 2 and 4 hours per day. This is not just symptom management, it's a psychological restoration. The ethical landscape is complex. On the positive side, APCS avoids the controversies around embryonic stem cells. This respects moral concerns and allows international regulatory approval, ensuring diverse, inclusive trials. And another ethical advantage relates to safety, using a patient's own cells that lowers the risk of human rejection, which aligns with the principle of minimizing the harm, particularly important for vulnerable elderly population. However, these are the serious ethical challenges. First one, the cost, currently estimated $1 to $2 million. It limits access to poor patients. This raises concerns about equity, a potentially restorative therapy risk becoming a privilege rather than a universal medical advancement. Secondly, long-term risks remain uncertain. While a tumor formation has not been observed in controlled trials, the risk is not zero. Informed consent becomes complicated because many PD patients experience cognitive decline. So, researchers must ensure that consent is genuinely informed and not be influenced by desperation.
Stem cells provide a new foundation for treating disease once considered irreversible. Innovations like iPSCs, gene editing, exosomes, and 3D bioprinting move medicine toward regeneration, and Parkinson's disease demonstrate both transformative potential and the ethical responsibility required. And with careful oversight, stem cell therapies can may redefine the future of neurological medicine.